Sean bienvenidos a un nuevo plano.
Bienvenidos a un nuevo plano.
Un nuevo viaje.
Un nuevo viaje.
Un nuevo viaje.
Donde la visión es bidireccional.
Bidireccional. ARI.
ARI. Exposición comercial de tecnología oftalmológica.
Introducing the Intensity IOL. We created an innovative algorithm, DLU, Dynamic Light Utilization. It allows optimal utilization of light, uncompromised eyesight with minimal side effects. Intensity is a high-quality lens with top production standards. With a lens profile that has smooth, symmetrical distribution of 12 steps with different heights, allowing it to adapt for maximum compatibility to the different states of pupil dilation and constriction. Intensity provides 46% less light loss compared to its competitors, allowing continuous vision starting from a distance of 40 centimeters and to infinity, with a defocus curve allowing 6/6 and beyond visual acuity. The result? Vision redefined. Intensity by Hanita Lenses.
Muy buenos días, queridos amigos. Estamos hoy en este precioso día de Alicante. Os saludamos desde Visu Miranza, desde el edificio en el cual tenemos la producción de este ARI 2024 y vamos a presentaros el área 2, que abarca las dos importantes áreas de la córnea y de la superficie ocular, que van a ser presentadas por Jorge Alió del Barrio y José Luis Güell. José Luis, supongo que estás allí. José Luis está ahora mismo online. Hola, buenos días, ¿cómo estás? Muy bien. ¿Y vais a conducir la sesión?
Muy bien.
Estupendo.
Sí, preparados.
Muy bien, Jorge, pues tienes la palabra y comenzamos. Muy bien, así me gusta. Adelante entonces.
Muy bien, muchas gracias. Para mí es un placer compartir esta sesión con el Dr. Güell, que como sabéis es un prestigioso especialista mundial en el área. Y vamos a empezar a tocar la superficie ocular, ¿de acuerdo? El contacto entre la superficie ocular y el ojo seco. Tenemos un panel de expertos de gran nivel internacional, empezando con el Dr. Víctor Pérez del Bascom Palmer, Rohit Sethi de la India, Eric Donenfeld de Estados Unidos, la doctora Mesti, y en el panel de debate nos van a acompañar el Dr. Rafael Barraquer y Maite Ariño. Y sin más dilación, vamos a empezar ya con el primer tema para no coger demora desde el principio. Va a ser el profesor Rohit Sethi sobre Innovations in Dry Eye Disease Treatment. So please, Rohit, go ahead.
Hello, I'm Dr. Rohit from Bangalore, India. Thankful for the Congress for this opportunity. I'm going to speak today about innovation in dry eye. These are my financial interests. I do have research grants from some of the companies who work on dry eye. When you look at the literature, dry eye is the most common cause, both in refractive surgery and also in daily practice. There are a lot of these symptoms which patient comes to us may all link to the same concept of a bigger pattern of how the dry eye is working today. The changing lifestyle and evolving immunology are probably one of the main reasons of this complex nexus. The change of dry eye pattern, the inflammation is going hand in glove now. So what is important also, especially for a refractive surgeon today, is the role of the basal inflammation threshold, which is the existing inflammation when you're probably planning a refractive, cataract, or any surgeries today. There are two main important pathways which control this threshold. One is the TNF-alpha pathways through its mechanism of multiple chain of events and how it works on the pro-inflammatory genes to the NF-kappa B pathways. And TGF-beta pathways, again, working on the multiple changes in the way the wound healing occurs. So how do we measure these factors? It's very challenging sometimes to understand these factors because most of our measurement is clinical or imaging or topography based, and we usually give an immunomodulator or a lubricant or a steroid for these patients. But when you look at the molecular biomarkers which are responsible for this may precede clinical manifestation. We can look at specific targets. Refractoriness to therapies is important. Objective monitoring, not just subjective way of looking at it. Address the discordance between sign and symptoms. That means you may not have any signs, but symptoms are in plenty, and quantitative results is what we need to look at. So we looked at whether we can look at a complete new dimension in dry eye treatment, where we look at how rapid it is, ease of operation, non-invasive, and multiple analytes. And we could look at tears would be one of the factors, and we call it the tear biomarker project. The Shermer strips, what you do, would be a potent place for looking at the biomarkers. And initially, we started preserving, I call the pyramids of our research, multiple numbers of tear samples, maybe around 13, 14,000 dry eye patients was preserved. So whenever you would want to look at the research of these markers, we could exhume it like a mummy and then do this complex analysis of CB analysis or proteomic analysis were looked at. These were all stored at minus 80 degrees. Then we started looking, can we look at a point of care kit where it can be faster and it can come to your clinic? And we call the biomarker pathfinder. The idea was to identify, customize, and treat. And this pathfinder uses a microfluidic assay where you're looking at tears, which is extracted from the Shermer strip into these wells. We're using a buffer, and it's a fluorescent reader. And these were the common immunological markers which we were able to study. And now we have developed this AI pattern where you're looking at these markers, which are the common markers. You can bring in, this is not just for the tears, you can bring in aqueous, vitreous, tears, trabecular meshwork, blood, serum, anything can be brought in. And you can look at these pathways, all of these pathways are involved in these kind of markers. And you can see that you can get an analytics of how these markers work. And now based on the AI, we can look at healthy subclinical inflammation. This is your basal inflammation threshold, and then you have a predicted one. And what are these markers do? These markers have a role in inflammation, fibrosis. They have a role in epithelial healing. They have an activated keratocytes, how you can have a scarring. One where you're discordant. That means you may have more pain, but no stain. VEGF can be looked at both from the tears and the vitreous, and IL-10 is a protective agent. And you can see that these are all the factors which have a huge role in the outcome. How do I use my biomarkers to my clinic? If you predict them early, if you can check them early, if you can treat them early, probably then you can able to then identify them. And if you identify them, you probably would avoid patients going into scarring, pain, epithelial remodeling, poor nerve regeneration, and you identify them here and you pre-treat them. And that is what happens today with your ocular surface. If you identify molecules like TNF-alphas, then you probably have a great factor which could probably have an impact on your quality of vision post-PRK. TNF-alpha have a huge role in how a PRK haze happens. Look at this. Higher level of TNF-alpha, more the keratocyte myofibroblast, more haze. And your regeneration also changes. This is something which we presented recently. So TNF-alpha is a very good, strong molecular marker, both for your dry eye, for cross-linking haze, PRK haze, nerve regeneration, and multiple factors. So I'm giving you one analytics which can have a huge impact in how it can be looked at. We can also look at titrating the treatment. Now we have a lot of these molecules, and each of these molecules, there are different set of therapies which works. ICAM1, the lifitegrast, Zedra works well. Trahelose, which is in the excipient in many of the sodium hyaluronate, works very well. Some IL-beta, the Miboflo works well. Some IL-17, IPL therapy works well. So this has all been published by a team, and you can see that how it can work. Now let's look at certain scenario. This is a patient with coming for refractive surgery. The epithelium has got a lot of remodeling here. You can see that his parameters are very high. If I do a surgery on him, he may not be very happy and may end up in a lot of challenges. So what we did is that they also have a chance of him developing an ectasia, as we have published before. Here, we started him on cyclosporin for 3 weeks, and you can see that it's changed now. From these parameters have changed, and now I can choose to do a PRK, I can choose to do a Silk, Smile, or a LASIK, and I know that I'll get a better outcome. And it can be a cataract patients also. I can see how it works. And we also studied the role of biomarkers in different types of inflammation, and this is published in Cornea, and you can see that what biomarkers can actually be reduced in different types of dry eye therapies. So the way forward is we have to expand more number of biomarkers to it. We also can look at systemic validation. We can probably from this, we can look at the tau proteins and multiple other things which have a role in Parkinson. We can titrate your treatment, and I think it becomes very personalized in the way you are giving a therapy, the way you're looking at therapy. Like, for example, this is going to be the way the personalized therapy will come. And that is where the dry eye dimension will change. It's like giving an antibiotic based on the culture report. And now we are not looking at the immunoprofiling report. And thank my team of surgeons who helped me to make this presentation. Thank you. I'm ready for any questions now.
Thank you very much, Rohit. This has been a marvelous presentation. We're going to keep moving, and we'll do the discussion at the end. So now we're going to introduce Eric Donenfeld from the United States. He's going to talk about management of dry eye, how to deal with the different approaches. Thank you.
Hello, my name is Eric Donenfeld from New York, and today I'll be speaking with you about the management of dry eye, how to deal with the different approaches. I'm a clinical professor of ophthalmology at NYU. These are my relevant financial disclosures, and I do consult with a variety of different companies in the dry eye space. Let's start with a very simple concept, and that is the tear film is the most important refracting surface of the eye. Vision starts with a healthy ocular surface. All the recent advances in technology, whether it be refractive or cornea or cataract, are lost with even minimal disruption of the ocular surface. Ocular surface disease is the rate-limiting step for surgical outcomes, and ocular surface disease affects IOL calculations, topographic and wavefront ablations, postoperative healing, and quality of vision and patient satisfaction. The healthy tear film is a delicate balance of lipid, aqueous, and mucin components, and the outer lipid layer prevents aqueous evaporation. It's secreted by the meibomian glands, and the aqueous component is a complex mixture of proteins, mucins, and electrolytes. Current treatments to improve the ocular surface aqueous deficiency disease include the use of artificial tears, which is a mainstay, and we use both preserved and I prefer non-preserved tears. Nutritional supplements have been shown to be important, especially those that contain omega-3s. Topical immunomodulators were really what changed our approach to dry eye, with the first being cyclosporin and then lifitegrast, now all being FDA approved to improve aqueous deficiency dry eye. Topical steroids have a long history. Newer therapies such as tear secretagogue, including varenicline, and new drugs that are coming are very optimistic to be helpful for dry eye disease. Punctal occlusion can be performed in many different ways with a new treatment you'll be hearing about a little bit later. Hydroxypropyl cellulose inserts are good for the most severe dry eye cases, and finally, for those patients who have dry eye and nothing else has worked, serum tears is an extraordinarily helpful way of managing dry eye disease. One of the basics of dry eye management is that BAK or preservatives in tears and other medications cause collateral damage. And whenever dealing with dry eye, I try to have a non-preserved product available to improve the quality of the tear film. Dry eye is also episodic. It can be seen in dry flares in which patients will develop dry eye that will come and go over periods of time. When patients only have a few dry flares a year, sometimes using intermittent dosing with corticosteroids can be very helpful for managing these types of chronic diseases that only impact on the patients under severe circumstances. A new therapy I'd like to show you here is a cross-linked hyaluronic gel, which is a new approach to lacrimal occlusion. Here you see lacrophil insertion, in which the hyaluronic acid is inserted into the punctum and into the canalicular system. It provides better punctal occlusion than plugs, it's more comfortable, and it lasts for 6 months. Finally, as I mentioned before, serum tears is the fluid component of blood after clotting. Blood is spun down, the red blood cells are discarded, and the serum tears left behind that contain lactoferrin, growth factors, etc., are left behind that provide a optimal growth and migration for ocular epithelial cells. And I find this to be the most helpful therapy that I have in patients with severe dry eye disease, including persistent epithelial defects and neurotrophic keratitis. Inflammation is a key component of dry eye disease. It can cause ocular surface and tissue damage, and it presents as a continuous cycle with ocular surface stress leading to inflammation, tear film instability, and finally poor quality of tears. Breaking this cycle of inflammation is key to reducing dry eye disease. The first anti-inflammatory that was approved in the United States for managing dry eye was cyclosporin A. It was a systemic immunosuppressive agent, and it was shown to inhibit T-cell activation, enabling patients to produce their own tears. And in clinical trials beginning 25 years ago, it showed that cyclosporin A could increase tear production, improve Schirmer scores, reduce corneal staining, increase goblet cell density, and finally reduce patient reliance upon artificial tears. Lifitegrast was next approved by the FDA, and this was the first drug that actually improved the signs and symptoms of dry eye disease, and this was the largest study on dry eye that I'm aware of, with over 2,000 patients participating, and the primary endpoints were inferior corneal staining and visual analog scale showing eye dryness scores. In this study, 3 out of 4 patients who received lifitegrast, 3 out of 4 studies in which lifitegrast was given showed improvement in inferior corneal staining at 12 weeks. Moving on, we know about aqueous deficiency dry eye, but probably a more important concept is dry eye patients having evaporative dry eye. And the great majority of patients have evaporative dry eye, with approximately 86% of patients either having primary or mixed evaporative dry eye. So when you think of dry eye, don't forget meibomian gland dysfunction. Meibomian gland dysfunction is evidenced by chronic blepharitis, pouting of the meibomian glands with neovascularization of the lid margin, acute chalasia, and one of my favorite signs is saponification, or a foamy tear film, seen here on the picture on the lower left. From meibomian gland dysfunction, patients will complain of burning, foreign body sensation, fluctuating vision, filmy vision, dilated meibomian glands, chalasia, toothpaste-like expression from the meibomian gland orifices, and thickened lid margin. The therapy for evaporative dry eye starts with lid hyperthermia, heating the lid up to melt the oils that have become solid at body temperature, allows them to be expressed. Hypochlorous acid is an anti-inflammatory therapy that's been shown to be effective. Nutritional supplements, especially those that supplement omega-3s, have been shown to be effective for dry eye management. And topical azithromycin, which is a macrolide antibiotic, given topically twice a day for 2 days and then once a day for a month, has been shown to open the meibomian glands themselves. Topical lotilaner, which is approved for Demodex blepharitis, also has a very important role, and we found it to be very helpful in managing meibomian gland disease. And finally, oral doxycycline can be extremely helpful in managing these patients, and keep the dose low, just 50 milligrams once a day, but I usually dose it for 3 months. Thermal pulsation can be helpful for patients who don't want to use or can't use hot compresses daily, and these have been shown to be effective and reducing symptoms for over a year. Finally, in conclusion, management of the different aspects of dry eye are important. Differentiating between aqueous deficiency and evaporative dry eye is key. Dry eye is underdiagnosed. It affects quality of life, and recently improved treatments now in clinical trials will greatly enhance our ability to manage dry eye disease in the future. Thank you very much.
Thank you very much, Eric. So now we're going to actually continue with this same topic, and we're going to expand it by the treatment with dry eye associated with meibomian gland dysfunction by Dr. Amesti. So thank you, Dr. Amesti. Please, you can start.
Hello, my name is Alejandra Amesti. I work in Visum Miranza, and thank you very much for the invitation. I'm talking about treating dry eye associated with meibomian gland dysfunction and exploring breakthroughs in dry eye management. The challenge here in treating dry eye disease is that we are very common to conventional treatments. Those treatments like artificial tears, ointments, anti-inflammatory medication, punctal plugs, eye masks, supplements, and many lubricants have a lot of things in common. The most important thing is that they have limitations. They have only short-term relief. They cannot address the underlying causes of the meibomian gland dysfunction. They are only conservative treatments, and we need to innovate for long-term solutions. If we think about the factors associated to dry eye disease, especially for evaporative meibomian gland disease, dry eye disease, we talk about mainly meibomian gland dysfunction and dermatological problems. And all those have in common that they cause meibomian gland dysfunction. So if we think about the skin, probably we are going to improve the dry eye symptoms to our patient because we improve eyelids, we improve the skin, and we will probably improve the meibomian gland dysfunction. In the circle of dryness, so meibomian gland dysfunction is in the center, and by treating them, we could improve inflammation, we could improve the symptoms of the patient. So what could we do to improve this dysfunction? We have demonstrated, and there is enough evidence, that IPL in ophthalmology can eliminate abnormal vessels, can eliminate telangiectasias of the eyelid. They inhibit the progression of inflammation, reduces the osmolarity of the tear and restore it to normal values, repairs the morphology and the functionality of the meibomian glands, because we can also see how the anatomy of the meibomian glands are better after IPL treatments. It also reduces infections because it destroys some bacteria, some demodex, or any parasite that can live in the eyelid. So improve also the microbiology of the eyelids. IPL is a light, but it's a filtered light. So only the wavelength we select is passing through the skin. And the main receptors on the skin are the chromophores. The chromophores on the skin, especially the skin of the eyelid, are the hemoglobin, the melanin, and water. For example, if a patient has edema or a lot of blood vessels, the energy is going to be absorbed in a better way than without vessels or without edema. If we think about the action, how IPL can improve this situation, this meibomian gland dysfunction, we have to think about heat. The thermal effect liquefies the content of the meibomian gland, and also, as we mentioned, we can destroy bacteria on the eyelids. Also, it has an analgesic and biostimulator factor, and it reduces inflammation by destroying blood vessels of the skin. For these reasons and for this action, we started doing an IPL study in dry eye disease in 48 eyes. As a first pilot study, we measure ocular surface disease index, OSD, symptoms score with BAS scale, frequency of administration of artificial tears in our patients, breakup time in MS39. We measure also all the keratograph parameters and breakup time under slit lamp. We have noticed that IPL in this study improved dry eye symptoms, not only in the OSD scale, but also in the BAS scale. Also, IPL decreased the use of lubricants in our patients in a significant way. IPL also improved the breakup time, measured with the MS39, and as we can see in these tables. IPL also improved, surprisingly, the meibography of the patients. We could see that improvement in the keratograph pre and post treatment. We didn't see any change in the height of the meniscus tear. with these good results, we started a second study with 60 eyes, evaluating also the intense pulse light directly applied over the eyelids. And we measure all things again. 37% of patients had a breakup time considered short or very short and before IPL, and that was reduced to 33% of the patients. And the mammography, surprisingly, also showed a statistically significant improvement after the 3 IPL sessions. So this is a very, this is a patient before and after. You can see longer meibomian glands on the picture of the right. Having this in consideration and seeing all the effect in the meibomian glands, we decided also to start the same study in Calaisian patients to study the intense pulse light with meibomian gland dysfunction expression for Calaisian management. In this case, we applied not only the IPL, but also did meibomian gland expression after the treatment with Collins forceps to improve the drainage of the meibo. In this Calaisian study, we studied 26 Calaisians, and we noticed a 96% of efficacy, known as efficacy reduction of almost all the lesion on the eyelid. Obviously, expression of the meibomian gland was done after the IPL session to also improve the drainage of the meibo. The protocol, or the treatment protocol, was first a treatment over the lower eyelids and cheek with a large light guide that you can see in pink, and then another pass over the upper and lower eyelids with a smaller light guide in blue, with a lower energy, no more than 10 to 16 millijoules of energy over the eyelids or when we're applying directly on the eyes. 42 patients require 1 session to reduce the amount of the size of the Calaisian, but 50% require 3 sessions. So normally we do, for these cases, 3 sessions to reduce the Calaisians. Here are some examples of patients before, after treatment. You could see that this patient had a little hemorrhage in the area of the Calaisian, which was good because the energy is absorbed by the chromophore hemoglobin in a better way when the eyelid is without hemorrhage. So the improvement was significant. It was very evident after treatment. Or this case, before and after, how redness disappeared, how the Calaisian drains very good. Here we can see not only the improvement in the eyelid aspect, in the edema of the eyelid, but also in the redness of the conjunctiva. The redness of the conjunctiva is also a good a sign of improvement after IPL. And that's also seen in patients with glaucoma using drops like monopers or prostaglandins in general that cause a lot of redness. And they have a very, very good resolution after IPL treatment. We not only treat the eyelids, when we treat the Calaisians of those patients and we treat those cheeks, we started seeing that not only eyelids were better, but also the skin was better, like this melasma after the IPL sessions. Several patients with not only 1 lesion, but several lesions after 1 session improved dramatically, because those are patients that are requiring surgeries many times. So if you, instead of surgery, do a treatment that you can be done in the clinic, in a clinical setting, is much comfortable for them. Other dermatological conditions can be also be treated with IPL, like this blepharitis, but sometimes with drops is not enough because it's a skin problem, so IPL will improve in a better way those cases. So now we are doing more combined treatments because we need to treat not only the eyelids, but also the skin on the cheeks to improve dry eye symptoms. If we think again about the factors associated to dry eyes, we have skin conditions like rosacea, dermatitis, ichthyosis, and many dermatological problems that will lead the area to have many, many vessels that will increase the inflammation of the eyelids and will cause meibomian gland dysfunction. Here you can see a patient treated before and after 3 sessions of IPL using the H-spot telangiectasia protocol. You can see how the lid aperture is better, how the redness of the eyelid is better, the conjunctival erythema is better, And not only the photorejuvenation that is very obvious on the skin, but also the eyes are photorejuvenated after IPL. These other skin problems are also treated, but we are treating not only skin, but also the eyes, because this rosacea patient has chalazions, and we are treating the eye at the same time as we are treating her skin. Obviously, for the skin, for the cheeks in this case, we are treating with higher parameters than the parameters we use in the area of the eyelids. For this swelling, this edema, before and after treated IPL treatment is significantly better. So we will only succeed when we understand that treating periocular skin conditions will improve dry eye disease symptoms, because we are treating the underlying cause. We are treating the meibomian gland dysfunction, and for that, the inflammation. Do we really need a slit lamp to see she is doing well after IPL? I'm pretty sure you know that she's much better after the IPL treatment, and it looks like she had a ptosis repair that I didn't do for her. So I'm very happy with my IPL patients after treatment, not only the eyelids, not only the skin, but also dry eye disease. To conclude, why IPL is a game changer? I think because it targets the root cause of meibomian gland dysfunction. The eyelids and its meibomian glands and the dermatological skin problems are closely related to the loss of tear film balance. It's a safe, effective, and non-invasive solution. We should increase the adoption in eye care practice, and oculoplastics specialists must be involved in post-diagnosis and treatment, because we are treating skin conditions and eyelid problems. Continual advancements in this technology should be done like we have done in blepharitis and chalazion, because we have seen that conservative treatment are not enough and should be limited to primary care, since there is evidence that more intensive treatments such as IPL are more effective. Thank you very much for your attention.
Thank you very much, Alejandra. So now, before the discussion, we're going to see one last presentation from Professor Víctor Pérez from the United States, in Bascom Palmer. It's titled Estesiometría y Patología Corneal. So please, Víctor, go ahead.
Good morning. My name is Dr. Víctor Pérez. I'm Professor of Ophthalmology at the Bascom Palmer Eye Institute. And my role today is to talk to you about stesiometry and corneal pathology. And I want to thank the organizers of ARI24 for the invitation to participate in this virtual symposium. These are my commercial relationships. And we understand now, thanks to the neurotrophic keratitis, that certainly corneal sensation is very important for corneal health. We're very familiar with the McKee classification of neurotrophic keratopathy, especially stage 3. And stage 2, now it's becoming a significant problem as we have therapies to treat early disease and prevent further damage. How we do that? Well, it does not only relates to neurotrophic keratopathy, but there are other diseases of the cornea and the eye that have alternation of corneal sensitivity, included in this side of the slide, but also systemic diseases that can present with corneal nerve abnormalities such as Sjogren's syndromes and other peripheral neuropathies. And more important, more interesting, and recently, neuropathic ocular pain, which become related to not only medications and surgeries, but as its own entity. So it's very important to assess corneal sensitivity. If we can assess and describe nerve disruption, we know that leads to decreased tear production, decrease of blink frequency, dry eye ocular disease, and others. The problem has been how we detect corneal sensation. Of course, we've used stesiometry, which allows determining the corneal sensitivity, use information about the state of the corneal nerve at their function, and the assessment is critical in the assessment of these diseases, management, and follow-up. When we think of corneal stesiometry, we think of contact stesiometry with Gaucher-Bonnet. We know the limitations. First of all, it's rarely available now. It's not accurate. It's very difficult to reproduce and use. So that has limited the role of us physicians using corneal sensation as a biomarker of corneal pathology and disease. But this is changing. Early on, our good friend, Dr. Carlos Belmonte, developed a non-contact stesiometry, which now has been adapted into a friendly user non-contact estesiometry that can be used in the clinic. Working with the company Brill Engine here in Barcelona, we develop a non-contact estesiometry that measures corneal nerve function. It can be placed in the slit lamp. It's portable. There's 5-level stimulation based on pulse of air. The method is quantifiable. You can quantify it, and it allows 6 different corneal function status. It's electronic, precise, the position in the slit lamp, and it shows you data. We've used it, showing the reproducibility. These are the 6 levels that it can classify corneal sensitivity. It can be mounted in the slit lamp. This is how we use it in my clinic. And basically, the patient is stimulated with 8 different levels of millibars, so it's quantifiable and very easy to use. We actually tested the intra-observer variability between observer A and observer B in my clinic at different levels of stimulations, and you can see that there was no difference between the observers' evaluation. The way that this works, your patients, it's placed in the slit lamp, a puff of air of the level is applied, and the patient says is it response or no. This is a Pearson correlation between observer 1 and observer 2 at level 3 and level 4, which shows perfect correlation, and we have the similar data for all the other levels. So we tested this in ocular conditions where corneal sensation is altered. First of all, we look at patients with dry eye. We had our controls, dry eye patients, all screened by the questionnaire and ocular surface score, and of course, patients with neurotrophic keratopathy. And when we look at our data, and these are the different levels of stimulations, 2 millibars, 4 millibars, 5 millibars, 8 millibars, just to give you a comparison, a puff of air for the pressure, intraocular pressure measurement, it's 80 millibars. So this is very sensitive. And when we do a dose response of a millibar stimulation, the percent of patients receiving the stimuli, you can see our control patients already detecting at level 4 to 5 millibars. And in the dry eye patients, there are different variabilities. Interesting, our neurotrophic patients, this is kind of the positive control, show decreased sensation to stimuli, demonstrated that this non-contact estesiometry can be used in clinic to look at corneal pathologies. What about patients that have medicamentosa, specifically patients that are using glaucoma? Hypotensive medications are known to cause medicamentosa, decrease corneal sensation, ocular surface disease, but we cannot monitor. So we actually use the non-contact esthesiometer in our population of patients that have been undergoing topical glaucoma medications. And you can see at the esthesiometry measurement that patients with glaucoma medications, their corneal sensation was decreased markedly as they could not detect anything until 8 millibars of pressures. And that correlated with ocular surface disease, staining, tear breakup ton, and tear meniscus height. Similarly, this can be applied for refractive surgery. We're presently doing a large study on patients with refractive surgery, but in my clinic, we look at patients that have undergone a penetrating keratoplasty and use this device to look at their corneal sensation, and compared to controls, it's decreased, but it's present. So now we're using this technology to monitor our corneal transplants and assess if corneal sensitivity can be used as an early marker of corneal failure or rejection. So with this type of technology, we can start developing algorithms for therapeutic decisions for dry eye disease. We could esthesiometry way early in the evaluation of our patients, and that will be the recommendations. And in patients with dry eye that have altered corneal sensitivity, it can help move our algorithm into different forms of therapy. Similar for glaucoma medications, you can have patients screen for esthesiometry and decide if patients that are on glaucoma medications starting to develop decreased corneal sensation and make early decisions, changing medications, or even doing early surgery to minimize the use of preservative or medications. And for conclusion, the cornea is the most dense innervated tissue in the human body. Corneal nerve triggers 3 protection mechanisms: blinking, reflex, tear secretion, ocular wound healing. Corneal sensitivity provides important information about nerve function and ocular surface health and disease. If there's altered corneal sensation, we can be used to monitor all these forms of corneal pathological diseases: dry eye, neurotrophic keratopathy, medicamentosa, anterior segment surgery, contact lens wear, diabetic keratopathy, etc. The new contact esthesiometer has the ability to perform precise, quantifiable, and reproducible evaluation of the corneal nerve function in an easy and safe way, and including non-contact esthesiometer in a complete ophthalmic examination will allow for a global assessment of the ocular surface health, comprising of early diagnostic of patients at risk of developing disease, surface disease, and also timely treatment to those to prevent development of significant damage of the ocular surface. Thank you very much for the invitation, and I'll be around to answer any question. Thank you.
Thank you very much, Victor. It has been a pleasure. So now we're going to open the time of the discussion, and if you want, Dr. Well, you can take the lead, and we can start as you prefer.
Okay, Jorge. Just a quick question. I presume that the speakers beyond Alejandra, of course, that I can see her face in front of me, but they are not available. No. So I think that we cannot ask neither Victor nor Eric or Rohit. No.
Yes, seems that they are not online. They are confirming me. So it's the four of us.
Okay.
And Professor Alio.
Okay. Perfect. So my first question would be how regarding the Rohit lecture, how useful do you think that would be to have this set of biomarkers detection before any corneal procedure, from your point of view? Because we have, in our country at least, some tests for evaluating inflammation, like MMC, and I don't think that we regularly are using it. So what do you think, Alejandra, and especially Maite? What do you think about that?
Hi, good morning to everyone. Thank you very much, Jorge and Jose Luis, for inviting me. I don't know if you can hear me properly. I think, Jose Luis, I think objectifying the patient's illnesses is and providing not only objective but numerical data to establish the degree of the disease helps them a lot and helps us as well to determine the treatment we're going to follow and to see if there's any improvement or deterioration. So I think objectifying is important, and if that includes if we're going to be able to analyze the inflammation mediated, I think we should incorporate that analysis before many of our surgeries, especially before refractive surgeries. I don't know if you do it on regular basis.
Well, that's what I was saying, that I think that we all have, and Jorge, I would like also to hear your opinion. We have incorporated dry eye evaluation before most of our corneal and intraocular refractive procedures, but I don't think that we are going so deep that we regularly evaluate inflammatory markers. Obviously, ideally, I completely agree with you, but the reality is that we have some of these markers available in our market, and I don't think that most of us are using them. So the other issue is that how frequent in your daily practice is do you change your, for example, IOL indication in front of this preoperative evaluation? And Jorge, what do you think about that? And
yes, so I think it's very interesting actually what Rohit is telling us, because he's saying, look, we can actually look biologically those patients that are going to be on risk. No, of course, we all see or we can identify meibomian gland dysfunction or clinical dry eye pre-op. So probably the value is to identify those masked patients. I see the two problems. I think it's highly interesting, But on the other hand, there are choices. First, our reality in Spain. As we all work here, we know how is the low-cost market today on laser refractive surgery. So if we want to do high-level refractive surgery, those clinics that we're doing high-level refractive surgery, this is going to involve an extra cost to the patient, and it's going to have also an impact on competitivity, that in the end is something that also should be taken into account, not the cost of effectiveness of everything we do. And if we are going to be less competitive by increasing the costs to patients, that is also other point of view to take into account, and let's see what do you think about. Also is that's very interesting because he said, if we, for example, identify interferon alpha high pre-op, then we can treat with anti-inflammatories pre-op. That's going to make, theoretically, our risk of haze lower. But the question is, why these patients have, without having clinical signs, why they have these markers high? And so probably it's because they have this genetic predisposed to have these high levels. So the treatment, for how long it should last? For only pre-op, up to 3 months, 6 months. So still there are many questions where we don't know, basically, because if we do pre-op, we do nothing post-op, and then the interferon alpha goes high, then the risk of haze is going to still be there. So I think it's something extremely valuable, but probably we need to work on that and probably also see what is the space on the reality of some countries like Spain, where the low-cost laser refractive surgery is established, and with something that we need to face every single day.
Yes, I agree with you, Jorge. There are many questions still. The point is that we should make this, in order to have responses, to know, for example, how long this treatment should be maintained in those cases where we had some pre-op non-clinically significant alterations of the biomarkers, or how long do we need to follow the treatment. We all need to have these tests extremely cheap and easy to be used, because if not, probably as a standard evaluation will not be put in practice. That's what I think. But just for a question of time, let's move to Alejandra, because Alejandra, you very nicely showed us how useful is the IPL in many clinical different situations. I've seen that you are always talking, when you are treating chalazion, you're talking about chalazion, but not the active inflammation, what we call in Spain orzuelo.
Orzuelo.
Yeah. So the point is that, do you normally wait, or do you recommend to wait until the inflammation with topical treatment or with oral treatment has diminished before using the IPL? Or do you think that we can use IPL straightforward as soon as you have the inflammation high?
Normally, we tend to wait. Normally, in what is published is to wait around 8 weeks. By the time the patient arrives to the specialist, like ophthalmologist, normally that time has gone. Okay, so when the patient comes to the clinic, normally they are ready to be treated. The thing is that the treatment is not going to do any harm. Obviously, if there is infection on the skin, if there is a wound on the skin, IPL is not recommended. But if the chalazion or the chalazion is acute, the response is going to be good anyway, because it will treat blood vessels, it will treat edema, it will treat the inflammation, it will reduce the inflammation. So I don't think we have to wait 8 weeks like the studies show to treat the chalazions. I think an orzuelo can be treated also with IPL, but obviously for this study, we only included patients that had more than 8 weeks of chalazion, of duration of the chalazion. But it's not a contraindication. You can treat an acute lesion like an orzuelo, and you will have a good response, except if the skin is affected. If there's a skin wound, it's better to put antibiotics first, because the layer of the skin is affected. So, but the rest of the cases, IPL can be useful.
Okay, and for you both, Maite and Alejandra, after a standard not for chelation, for any other indication, mostly meibomian gland disease, for any IPL treatment, in your experience, which is the mean, more or less, standard regression of signs and symptoms of these patients? Because most of the times I presume that with one treatment, you will not have a full recovery of someone who has had meibomian gland disease for many years. So which is your mean standard regression of signs and symptoms?
That's a difficult. Okay, Maite, you.
Oh, go ahead. Go. So
I think that.
Okay.
Yeah, let's. Jorge and me will order. Maite first.
Okay.
Okay.
You mean how many sessions before the patient improves?
No. My question is that after one session, so
yes,
it would be
after one session, I would say 20% of my patients improve after one session, and after two sessions, I would say between 50 and 60%, and after three sessions, definitely 80% or more, and I usually do 4 sessions. That's my rate of improvement.
Separated how much? How long?
2 to 4 weeks.
2 weeks. 2 weeks before one session and the other one.
Okay, this is important to be known by.
And I had a question for. Sorry, I had a question for Alejandra. Do you apply gland expression after each session, or only for when there's a chelation?
I do the meibomian gland expression for every patient: dry eye disease, chelation, blepharitis, everything. Even patients with rosacea, and I'm treating the skin, I do meibomian gland expression. I think it's very useful. And answering the question that Dr. Well mentioned before, I explained to my patients that when you want to remove your hair from your legs or for your arms, you don't do one session, because there are several follicles, and no clinic will guarantee to remove all the hair in one session. So the same thing for the meibomian glands. Meibomian glands, we have 30 to 40 meibomian glands in the upper eyelid and more in the lower eyelid. So the aim of the session is not only to remove the chelation. The aim of the session is to drain as much as meibomian glands as we can. So I explain in a way they can understand. We need several sessions to remove hair, the same way we have several sessions to improve meibomian gland dysfunction.
Okay.
It's also important to remind them that it is a chronic disease, that it's not gonna, IPL is not gonna improve for good. It's gonna have a limited effect. So that they're gonna need reminder sessions after 4-6 months, approximately.
This was my question. Jorge, excuse me.
Yeah, sorry. No, it's because it links the talk of Eric and Alejandra about the doxycycline. Do you use it when? Because on my experience, I mean, when I was training in UK, I used to use a lot of doxycycline, but I've realized that since I arrived to Spain, really the chances of non-tolerating of gastric problems with the doxycycline are very high, and also here in Alicante that we have a lot of sun, and also you in Barcelona. So what is the role of the doxycycline? Because I like it, it's true that it's very effective, but I struggle to have the patients tolerating the doxycycline. So do you use it when doses? What do you think about this, about the tolerance and alternative approaches with the doxycycline?
Doxycycline is a useful tool. However, I don't prescribe doxycycline for every patient, because many patients are going to respond very well to easier treatments or less invasive treatment. Normally, oral treatments are used not as a first line of treatment, especially for 2 reasons. First, the sun, the affection that can cause, and also because it's a contraindication for IPL. So normally combining both is not recommended. However, for severe cases like with very recurrent lesions on the eyelids, it's very useful.
Okay, just one comment, Jorge, and I would also like to hear Maite's and your own experience. regarding the Victor talk. I don't know if you have, well, I'm sure that you have observed that especially in our older recipients, when doing either full thickness or anterior lamellar keratoplasty, we are much more concerned about epithelialization problems than with rejection problems. Because in most of the cases, rejection is relatively well controlled either with topical and with systemical steroids, immunosuppressants in general, but they frequently have epithelialization problems. And sometimes they are significantly important. And what I have observed is that, or I think that we might, let's say, have some information that this will happen if we regularly evaluate corneal sensation in every patient, but especially in these older recipients. And perhaps if the sensation is significantly diminished, because it will be diminished in every single case, of course, especially if you evaluate the area of the corneal transplant. But if you evaluate the recipient ring and the sensation is really low, perhaps in these cases we should relatively quickly recommend either amniotic membrane transplantation or the constant use of a therapeutic counter lens. But I mean that in those cases where corneal sensation is significantly more depressed than standard, perhaps we should take some therapeutic measures much more aggressive than in the others. What do you think about that, Jorge and Maite?
So I think that's very interesting. Please, Maite,
Yeah,
you're the
Maite.
invited one, so please go ahead.
Okay, I agree with you, especially in those older patients. I taper down a little bit my steroids treatment until they complete, until the epithelium is completely healed. I usually lower down to 4 times a day instead of 6 times a day, and check up the patient very regularly. So until the patient is epithelialized, I see it every other day.
Jorge.
Yes. So my view is that the problem is going to be the reproducibility of the measurement. We have the lack of having available the Brill stesiometer. It's very useful, and we've tested. But the thing is that in order to do it on the periphery of the cornea, basically the patient has to move the eye, so the area you're measuring is not always the same point. And also in a patient that is requiring a corneal transplant is because there is an underlying disease, unless there is keratoconus, and this underlying disease could be altering the corneal sensation very asymmetrically all along the circumference of the cornea. No? So the thing is that what is going to be relevant? The overall, the central, the peripheral. So, and in the end, on my view, the epithelialization problems I see them mainly not in relation with the transplant, of course, but probably in relation with the underlying reason. For example, third transplant, ocular surface disease preparatively. So many times these patients that are having epithelialization issues are patients that already pre-op I can see that the epithelium was obviously abnormal and I was expecting problems. No, So although I think on research point of view, this is extremely useful in order to demonstrate any approach we do, what is the objective value. On the clinical basis, on the day-to-day, it's true that since you are seeing it, and many times already predicting it from pre-op regarding the staining, not sure if it's considering the reproducibility of the measurement is going to add a huge value on a regular clinical basis.
Well, of course, I cannot completely agree on that, Jorge. I really think that this is an important issue. I don't know how frequently you have epithelial problems in your elderly patients, but at least in my hands and during these last 30 years are really frequent, and they used to become a nightmare to deal with them. For example, I already have decided in any long time ago, as you probably know, in any of my either anterior lamellar or full thickness transplantation in herpetic recipients to use amnion at the end of the surgery on a regular basis, because I am so worried about epithelialization that is my standard. Despite of that, I still have in some cases problems, but this is my regular approach. In our very old patients, I also use amnion as a standard protection for at least the first 6 to 7 weeks. Also doing what Maite was saying, reducing slightly the topical treatment. But I really think that Brill, for example, now that you are talking about this instrument, should work on the capability of letting us evaluate. They already have some tools, but to evaluate the central cornea and the very peripheral. And this should be, I think, very helpful for us, because it's a quick measurements, can be done by the optometrist or by any other technician. And I think that if you, as we were saying, if you have this pre-op or immediately post-op data in your hands, this will change your therapeutic approach. But anyway, let's see. I think that we are on time, Jorge, and we will probably need to close this session, because Maite needs to run to her own lecture.
Okay, yes, of course. Thank you very much, Dr. Well. It has been a pleasure to share this session with all your knowledge and experience. And thank you to Alejandra, to Maite, and all the speakers that, for obvious reasons of timing, they couldn't be with us live, but we have enjoyed and learned a lot from them. So thank you very much, and we are coming back in 15 minutes with the satellite lesson of Medicontour. Thank you.
Thank you to you.
Bien, ha quedado bien.